Morning. Thank you very much for joining us for the September edition of Eggheads, the CHI's monthly breakfast presentation series. And also thanks everyone for your flexibility with our date change that we announced last week. If you know somebody who isn't able to make it, or you just want to rewatch what we saw here today, we will have a recording on the website posted later today is our goal. We really wish we could gather in person for these sessions, but we're making the best of it with these virtual presentations until it feels safe and responsible for all of us to get together and enjoy an actual breakfast with actual food around an actual table together. Very quick announcement. Next month, October, there will be no Eggheads webinar seminar. Instead, look for the release of the 2021 Colorado Health Access Survey. So sometime late October. We hope we will be able to announce a date very quickly here. So stay tuned to all your CHI channels. For today's webinar, remember, please use the Q&A button at the bottom of your screen, probably, to submit questions for presenters, and use the chat window to talk amongst yourselves, if just like you do if you were in person and maybe whispering to the person next to you. I'm going to be monitoring both the Q&A and the chat, as is my colleague, Deanna Geldens, who's making this whole thing work for us this morning. Remember, chat usually defaults to messages only to the presenters. So if you want everyone to be able to see your comment and interact, you probably need to manually change the visibility to presenters and all attendees. So let's practice that real quick. This is a webinar about missed care during COVID. So I'd like to ask you, was there a time since the beginning of the pandemic that you skipped medical care because of COVID? Let's just see what rolls in on the chat here. Oh, come on, don't be shy. I can tell you I missed my annual and or semi-annual dental checkups. Yep, deferred dental care. No annual physical for 2 years. Yeah, I took way more than a year for my annual physical, I remember. A lot of missed dental care here. All right, well, I think our small little unscientific sample is going to be borne out by the very large, more scientific sample that you're about to hear about. This missed care issue is really widespread and has a lot of implications, both short-term and long-term. So what CHI's team did is use the CHORDS Network, which we'll tell you about more in detail if you're not familiar, to see how healthcare visit volumes changed last year compared to what we would have expected based on what it was like in 2019 before any of us had ever heard of COVID. So visits were down for Coloradans of all ages, and they were down for many different services, including some that were just really downright dangerous to miss. Think cancer care. So we're going to be grappling with the impacts and challenges of this for a long time to come. And it's going to take all of us working together to make up for that lost time. Allie Morgan and Spencer Budd from CHI are here this morning to share these new data and insights from CHORDS, and which was just published this week after many months of work. I'm going to let them introduce the topic and themselves, starting with Allie.
All right, thank you so much, Joe, and happy Friday morning to everybody. We don't usually hold our Eggheads webinars on Fridays, and it's kind of a fun way to get to kick off our Friday and weekend. So wish we could see you all today, but thanks again for being here virtually. As Joe said, my name is Allie Morgan. I'm one of the directors at the Colorado Health Institute, where I have been since 2014, and I'm really excited to be here with you this morning, along with Spencer and our team, to share some findings from our newest report with you. While much of my work at CHI tends to focus on policy and legislative services, I also supported on the development of this new report on missed healthcare visits in 2020 with Spencer and a team of CHIers. And also years ago, I had the pleasure of getting to work with the CHORDS Network a little bit, and I will talk a little bit more about CHORDS. As Joe mentioned, it was the source of data for our analysis, and so I have some familiarity with that from a few years ago. I'm joined today by my colleague and the lead author of our report, Spencer. I'll let him introduce himself.
Thanks, Allie. Hi, everyone. Good morning. My name is Spencer Budd. I'm a policy analyst here at CHI. I've been with CHI for almost 3 years now. At CHI, I work mostly in the areas of health insurance coverage, affordability, and care access. With a focus on Medicaid and the individual market mostly. I'm happy to be here with you today at this, I think Joe called it a webinar seminar on this Friday to walk through these findings with you.
All right, and as is usually the case with CHI work, there's a whole other team that we could and should thank as well, but we just want to give special recognition also to our colleague Paul Preskin, who did a ton of work with the CHORDS data and analysis and was deeply involved with this project from beginning to end. So kudos to Paul as well. All right, I'd be curious to see in the chat maybe if this is anyone's first Eggheads with us so far at CHI this year, or maybe your first real exposure to the Colorado Health Institute in general. If it is, please share so we can welcome you virtually. And just a reminder, as Joe said, you probably need to manually toggle it to everyone unless you just want us to see it. For anyone who's not already familiar with us, briefly, CHI believes that good health policy is crucial for a healthier Colorado. We work to bring research, insight, and expertise to leaders across the state to support informed decision-making. In addition to providing a public-facing portfolio of work that's funded by philanthropic supporters, we consult with all kinds of organizations from community groups and hospitals to payers and government agencies. So please reach out to us if you'd like to learn more about our services, like facilitation support, strategic planning, or evaluation. We are always delighted to hear from you. So let's turn to today's topic. We released our newest report on Tuesday, as Joe mentioned. You can find and download a copy at this short link on the screen if you haven't already, or you can just go to CHI's homepage and it should be the featured report on the top left. This report is called Fear and Missing Out. And what it does is rely on aggregate medical record data to look at what kinds of care and just how many visits we believe were missed between March 2020 when the COVID pandemic started in Colorado through the end of last year. So as is typical with CHI presentations, we're going to start and end with 3 key takeaways. We're going to hit you with a lot of data and trends and such today. And so there are a few key things that we want to make sure everybody leaves here with today. First is that in total, the volume of visits to a set of front range providers, a large set, I'll talk about that in a minute, dropped by 1/4 during the COVID pandemic in our state last year. We'll look at the variation in those numbers at different points in the year. That's something that Spencer will walk through, but all in all, about 25% of expected visits never happened. Second, missed health care led to misdiagnoses, untreated health conditions, and the exacerbation of inequities among populations who faced barriers to access and care well before the COVID-19 pandemic started. And what all of this means is that we really need a concerted effort by providers, policymakers, consumer advocates, and others to reconnect patients with healthcare services and to address these either undiagnosed or worsened conditions that may have resulted from miscare. We expect negative consequences of this to reverberate for years to come, but we do believe that we can work together to mitigate the impact. And so we have a bit of a call to action as well. Before Spencer dives into the findings, I want to spend a few minutes to provide some details about the methodology behind our work, because I know this group and I know that we have enough data nerds on the call today that if I don't start here and give you some of the information up front, we'll get questions about it. So I promise we will get into the actual findings soon, but bear with me while I talk about some data and methodology first. The data in this analysis, as we've mentioned, comes almost entirely from the CHORDS Network. That is the Colorado Health Observation Regional Data Service. You can see why they use the acronym. CHI has supported this network since 2015, though it first began forming all the way back in 2009. There's a great research paper online detailing the origins of CHORDS. If you are interested, I might be able to drop that in the chat later for anybody who wants a little more background. But in short, CHORDS is a collaborative effort by a variety of healthcare partners, including behavioral health and public health, to share de-identified patient data from medical records for a variety of public health monitoring, evaluation, and research purposes. It's an amazing data source for us at CHI and for many others. You'll know if you're familiar with it, with a great group of folks behind it. So we always enjoy working with the CHORDS folks and appreciate the data source that they offer to us. CHORDS includes this medical record patient data from 14 different contributing providers on the Front Range. And of those 14, 12 contributed data to participate in the research behind the analysis that we're talking about today. Those 12 include 4 health systems, 2 community mental health centers, and 6 federally qualified health centers. Details on these providers are available, wrong screen, in the methodology appendix, which is found at the end of the written report, if you're interested to learn a little bit more about who these providers are. And thanks to these 12 providers, through this analysis, we were able to look at aggregate de-identified patient data from about 1.5 million Coloradans, which is about a quarter of the state's total population. Because of where the healthcare providers who contribute the CHORDS data are located, the majority of these patients live in one of these 10 counties. I won't read them to you, but you'll see that most of these are the state's largest population centers. So we have this huge swath of the Front Range represented. Still, we do want to be clear that this research and the CHORDS network is not meant to be not meant to be fully represented, of the entire state. Rather, it provides a large enough sample size that we believe it offers valid insights into changes in the use of various healthcare services by Coloradans during the pandemic and for other research for which it is used. As you all undoubtedly know, one of the great challenges of public health and healthcare research is attempting to quantify things that never happened. Typically, when we are having that conversation, we're talking about attempts to measure the impact of different preventive measures through public health, right? But in this case, we wanted to know how many healthcare services were missed in the first 10 months of the pandemic. These were often missed when patients chose to forego care, either because they were afraid, rightfully, to be venturing out when they felt like it maybe wasn't completely necessary, sometimes because people wanted to do their part to not overwhelm our healthcare systems when there were things like PPE shortages. Appointments were also missed, though, as a result of state orders in some cases, or because healthcare providers decided to postpone or cancel services for a variety of reasons. So to look at this missed care and to quantify it, what we did is compared in-person and virtual visits from a 42-week period that stretched from March through December of 2019, which we called our baseline period, with approximately the same 42-week period in 2020. I want to stress again, because I just said it quickly, that this included both in-person and virtual visits. We have heard a lot about the success of telehealth last year, and that is well-founded. I think it's widely accepted and acknowledged that telehealth served as a lifeline for many patients and providers, providing access to some really crucial types of care, especially behavioral health care. But by looking at both in-person and remote visits, one of the things we learned is that the rapid increase in telehealth we saw last year was still not enough to make up for the decline in traditional care visits. The time series you'll see in the graphics that Spencer will show shortly were divided into 1-week or 4-week periods. They use seasonally adjusted statistics to compare to roughly the same period the year prior. We did that to help smooth out these blips that you get in the data sometimes because of things like adverse weather events or the exact timing of a holiday that can sort of create some confusion in the data. And so we just wanted to smooth those out a little bit so we could really easily compare the visit volume. Emergency department visits are not reflected in the visit volume statistics from the CHORDS data. I just wanted to call that out because we've heard a lot about the pandemic's impact on emergency department use. Anecdotally, I've heard lots of things about people coming in and being sicker, for example. They are mentioned briefly in our report, though. And finally, the analysis did not include some other types of care, most notably acute inpatient services, but also radiology, laboratory services, non-billable communications like chats and texts. So while this data set that we used and that we'll talk about today includes a lot of different kinds of visits, we just wanted to be upfront that it certainly doesn't include everything. If you have any additional questions on our data or methodology, please feel free to ask them in the Q&A and we will address them if we can. Spencer will probably be your go-to guy for those questions. And if there's anything that we need just to get a little further into the weeds on, we're happy to bring things back to our colleague, Paul. I'm going to volunteer him, even though I didn't ask him before I mentioned that, and get his expertise if needed. So I will go ahead and turn it over to Spencer now to walk us through the analysis of the report.
Thank you so much, Allie. Great, so let's get into it. We're going to start off with looking at miscare over time with those time series graphs that Allie mentioned. So what happened to care volumes in March of 2020, and then how did that story evolve over the rest of the year? Sorry about that, a little bit of a lag there. So care volumes dropped to less than half of the baseline volume the week of March 15th. And that was when Governor Polis ordered the temporary closure of many non-essential businesses like restaurants, bars, breweries, and movie theaters. So I'm sure you remember that week in particular. So the volumes dropped to less than half the baseline as people responded to the threat of that emerging pandemic and some of those regulations that were changing and public health messages that were coming out. And just to reiterate what that statistic means, because we'll be showing you lots of similar figures, that means the number of visits the week of March 15th, 2020 was only 45% of the number of visits from the same week in 2019, which is the baseline. And I saw we had a question in the chat about whether our data is net of COVID visits. The data do include COVID volumes, so that is certainly baked in. The data don't include things like inpatient that Allie mentioned. We can talk about that more later, but you can consider that as we go through the data here. Sorry, my PowerPoint is jumping around a little bit on me. So expanding past those, you can see the data point here that we were just talking about. That's the 45% in March 15th. So this chart here is one of those time series charts. It's the week by week data for mid-February through early May, the early weeks of the pandemic. You can see that care volumes actually dropped again the following week. So that's that March 22nd week, which was when the governor announced a temporary ban on some providers performing voluntary or elective procedures. You can see that care volumes bottom out at a little over a third of the baseline volume, 36%, the last week in March. This was during the height of uncertainty around the spread of the virus and during that initial wave of pandemic-related restrictions and public health messages that I mentioned. And then you can see that volumes begin to rebound very slowly in the following weeks, but we can start to see a little bit of a rebound there. So expanding past those early weeks to look at March 15th through the end of 2020, care volumes were down a quarter compared to volumes from the same period in 2019, or what we call the baseline. So in short, I think this has been said already, but patients missed 1 in 4 of their expected healthcare visits during that period compared with the baseline in 2019. Now, with this chart, we can see that entire period. So from March 15th through the end of 2020, Each bar on this particular chart is a 4-week period. So that's different from the prior chart. These bars here, as you can see, if you look at the x-axis, are 4-week periods. And as you can see, care volumes continue to rebound fairly gradually over time. So by the beginning of June, total care volume had rebounded to about 3/4 of the baseline. That's that 76% figure you can see there. But what we don't see on this chart is that despite relatively low COVID case rates over the summer months, there wasn't a surge in visits to make up for previously missed appointments in the spring when those volumes were really, really low. Instead, we see just a pretty gradual recovery throughout the year. And that certainly has implications for the sort of health outcomes of Coloradans. So by late September, visit volumes had reached 94% of the baseline. So still had not gotten all the way back up to normal, had gotten fairly close. But then in October, volumes began to decrease again during that winter wave of coronavirus cases that happened at the end of last year. So that's the story of kind of the trend over time. And if you have any questions about that, definitely drop them in the chat and we'll answer those at the end. I'm going to move now to looking at that missed care by condition and by demographics. So first, looking at chronic disease and cancer, the CHORDS data show that visits for chronic conditions, so things like asthma, diabetes, high cholesterol, and high blood pressure, which we'll break this out in a second, those together decreased by 38% relative to the baseline. This is an important finding because patients with chronic conditions are, of course, at risk of adverse outcomes when their regular care schedule is disrupted. One data point on that, a national survey of primary care providers that was released in October of last year found that more than 1/3 of the clinicians who responded said their patients with chronic conditions were in worse health due to the pandemic, in part due to delayed visits to manage their care. And I'll note that that survey was relatively early on. It was released in October of last year, so almost a year ago. The pandemic also upended vital treatment, as Joe said, vital treatment for some patients with cancer. Visits for patients with a cancer diagnosis or a personal history of cancer were 22% lower between March and December of 2020 compared to the same period in 2019. We know from talking to some providers about this data, the pandemic disrupted some chemotherapy and radiation treatment schedules, forced some surgeries to be postponed, particularly early on. And in certain cases, cancer treatment periods or schedules were changed to minimize in-office exposure to try to fit the treatment in a way that would be most safe for patients and providers. So breaking out those two particular data points into some additional detail, you can see on the right, visits for patients with a breast cancer diagnosis decreased by 28%, while visits for those with a colorectal or lung cancer diagnosis decreased by 10% and 13%, respectively. Then on the left side of the chart, you can see those chronic conditions broken out. Those are all clustered around kind of 36 to 41%, but they were all down fairly significantly as well. So moving to behavioral health, we know that the pandemic strained patients' mental health, everyone's mental health really, while at the same time it limited their access to behavioral health care. So services related to depression decreased by 33%, while at the same time a Colorado Health Foundation survey found 1 in 2 Coloradans reported experiencing mental health stressors because of the coronavirus. So as you can see in this figure, visit volumes decreased for all of the behavioral health conditions in our data set. These are the ones that we have in our data set, and that goes for all of the charts here. Volumes for services related to anxiety decreased by 23%. Substance use services decreased by a smaller amount. You can see only 9%. This may be due in part to a particularly high need for those services in 2020. We're curious what your thoughts are on that. Another data point for that, in a different national survey, almost 9 in 10, so 85% of physicians said that the mental health of their patients worsened during the pandemic. And some physicians reported seeing more patients than usual for drug or alcohol use. Overdose deaths were also up in 2020, which is the year that we're looking at. Ali mentioned telehealth earlier. That's the other thing I want to tag on to here. The decline for all three of these services would have been even steeper if not for that explosion of telehealth services that we saw early on in the pandemic, and some of these behavioral health in particular has seen a big growth in telemedicine. So we just covered patients with existing conditions and how their care was affected in the short term. Other folks won't be impacted until further down the road because they missed routine screenings and diagnostic tests, some of which may result in misdiagnoses for a variety of conditions. We'll walk through the conditions we have in our data set. So for blood tests used to assess heart health and risk of developing heart disease, those were down anywhere from 11% to 23%. Wellness exams were mentioned earlier. A lot of people missed their wellness exams, either canceled it, postponed it, or just never got scheduled with everything going on. So those decreased by almost 50%. 47%, as you can see in the next slide here when we break all of those out. So as I mentioned, you can see in this chart all of the diagnostic and screening tests that we have included in the data set. So measurement of blood pressure, which typically occurs during one of those wellness visits or any other primary care visit, that was down by almost as much, 44%. Also on this chart, I want to call your attention to the EPDS on the left there, which is a postnatal depression screening. It was actually up slightly. I think that's the only data point we had in our whole data set that was actually up slightly, just 4%, but it definitely stands out, indicating that obstetric care may have been less impacted by the pandemic than other types of care. Again, this is relative and we're talking about averages, but we did hear from providers that it was harder to get some pregnant patients in for their regularly scheduled prenatal care that were showing up later or closer to their due date. So I imagine that one data point doesn't tell the entire story, but it provides us some insight into that care. Now we're going to look at missed care by age. So we're moving into those demographic categories a bit here. So the amount of missed care generally increased with patients' age. So looking at for the oldest age group in our data set, volumes decreased by almost a third. You'll recall that the decrease across all age groups or all Coloradans for kind of everyone in the data set, that was 25%. So 32% is the number for those who were older than age 80. We suspect that this is for several reasons. One, older Coloradans may have been more likely to avoid in-person visits because of concern over the coronavirus. They may have been a little bit more conservative in sort of the activities, including care seeking, that they chose to seek out. And again, we're talking about averages. We're not talking about individual folks who of course make different choices. So two, difficulties with technology may have discouraged some from using telemedicine as a replacement for in-person appointments. And three, because older Coloradans receive more health care on average than other age groups, this is really just kind of like a math reason. They were also more likely to have an appointment canceled or postponed during the early weeks of the pandemic because they simply have more visits that are scheduled. There are more visits that could be missed. Again, this is important because providers have reported their older patients losing strength and having new difficulties with their movement, with their balance, with their weight. Providers have also seen an acceleration of conditions like dementia and worsening of chronic illnesses like diabetes or heart failure and chronic obstructive pulmonary disease. So we're going to look at all of the age groups we have in the data set here. And you can see that trend of missed care generally increasing with age. You'll notice the exception is for those under age 18. Children under age 18 missed more care than most of the other age groups, as you can see there. And this, we think, is due in part to parents being forced to miss their children's regularly scheduled well child visits. Children under 5 in particular require a lot of different regular checkups to maintain and monitor their healthy development. We also know that for this age group, there was, and for really children, that 0 to 17 age group, there was less respiratory illness. So things like asthma were down, there were fewer injuries. Kids were, as we know, spending more time at home, less time at school, less time socializing, less time in daycare, and less time playing organized sports. So those respiratory illnesses and injuries were down, and that I think we're seeing in the data as well. But it's a little bit of an interesting story. So we're going to jump into that age 0 to 17 group more specifically here. So within that group of those under age 18, visit volumes decreased slightly less for children under age 2 compared to those who were in that toddler and preschooler range, and as well as those who are in the elementary school range. So we'll show you those data right now, which you can see. So we heard that this was likely due to an emphasis by pediatricians on well child visits for their youngest patients, particularly in the early stages of the pandemic when pediatricians were making decisions around prioritizing who they could get in for care. So despite that emphasis, visits for this group were down by more than a quarter. So that's more than the overall average of 25%. Despite that emphasis, that may, and this is sort of a similar reason to one I mentioned earlier, that may be because the number of visits a baby has in a typical year. So from birth until age 1, for example, Children's Hospital recommends 7 visits for that population. So there's just a lot of visits that need to be squeezed in there. Now we can contrast that with teenagers. They were still down 27%, but they decreased the least of these particular age groups, potentially because they tend to have fewer regularly scheduled visits, and because they can be more easily treated by telemedicine than those babies and really young children. So we also looked at this data by race. What we found was that populations with greater access to care prior to the pandemic were more likely to have missed visits during the pandemic. So I'll give you a couple of those data points really quickly here. Again, for all the populations in the data set, visit volumes decreased by 25%. Asian and white Coloradan visit volume decreased by more than that state average, so 32 and 28% respectively. Visit volume decrease for Black Coloradans was the same as the state average, so it was 25%. The visit volume for Hawaiian or Pacific Islanders and American Indian Coloradans was below the state average at 23 and 22% respectively. So those are the data points that we have there, but we know from data from the Colorado Health Access Survey that certain populations, Asian and white Coloradans, like older adults, which we talked about earlier, tend to use more care, have greater access to care than Coloradans as a whole. And those were also the populations our data showed missed the most care. This analysis here, it compares changes in care volume against a baseline where some populations have less access to and less use of healthcare due to historic structural racism. So someone who typically sees a medical provider several times a year may just have been more likely to have had an appointment postponed, canceled, or missed, or anything like that in the spring of 2020 in particular, when care volumes were at their lowest, compared with someone who sees a healthcare provider, say, once a year, if at all. It may also be the case that those with greater access to the types of care that can be more easily skipped and rescheduled later, such as preventive visits and health screenings, things that are definitely important, but rely on having pretty good access to the healthcare system. those folks may have been more likely to miscarry during the pandemic. So ultimately, we think this analysis is a little bit limited in the conclusions that can be drawn around race and ethnicity, and without context could potentially underestimate the disparate impact of the pandemic on populations of color. What many other data sources show is that the various effects of the pandemic have fallen hardest on populations of color. So this particular data point is an example, comes from Denver Post analysis last year. And it's just one of many examples that better capture the disparate inequitable impact of the pandemic. So we've set some time aside for discussion after just a few more slides, and we hope to hear your thoughts on these data as well as the other data that we've walked through. But first, I'm going to run through just a few high-level recommendations. So first, providers should proactively reach out to patients, those who have chronic illnesses, to check on their health status and to encourage them to seek care if they haven't already done so. Behavioral health services, especially substance use services, which we talked earlier, but really all behavioral health services are more important than ever. The demand is higher than ever, and the access is really difficult. But they need to be available to meet the patient where they are, whether that means inpatient or via telemedicine. Patients with new or worsening physical or behavioral health symptoms really should seek medical advice as soon as possible, even if those symptoms do not seem serious. Many Coloradans who don't have a chronic illness or a new or worsening symptom would still benefit from actually getting in for that wellness visit or important screenings for cancer, depending on what's recommended for you. For children and what we're calling youth, in order to head off the spread of non-COVID vaccine preventable diseases, parents and providers should work to make sure they're up to date on their immunizations. And once that COVID vaccine becomes available for that population, that will be important as well. So for some older adults who we've talked about a lot today, who have spent some of them have spent months more isolated than they've been in the past, and effort is needed really to identify them and to get back on track. I'm glad that we put this particular slide in here, even though dental health was not part of our analysis, because I saw a lot of missed or postponed dentist visits in the chat early on. Dental health is obviously a component of whole health and is really important. And that goes for sexual health as well. Coloradans should schedule a dental appointment if they have not done so recently, and should also speak with a provider if they have questions or concerns about their sexual health. So as Ali said, we always start and end with key takeaways. So to conclude here, I'll reiterate those three key take-home messages for you. First, in our data set, 1 in 4 healthcare visits were missed in 2020 since the start of the pandemic across all ages, races, and health statuses. Second, all that missed care has consequences, some of which we're already seeing and some of which we won't see until further down the line. And third, a concerted effort, what we were kind of just talking about at a really high level, but we'd love to hear more like specifically of kind of what efforts are needed. A concerted effort is needed to dig us out of the hole that coronavirus put us in 2020 and unfortunately continues to kind of put us in 2021.
All right. Or Ali, do you want to get going with some discussion questions, or should I chime in with a few from the chat?
Yeah, I'd love to kick us off, maybe just to get folks thinking about some questions if they haven't fully processed everything here. So Spencer and I have done plenty of talking over the last 40 minutes or so. We would love to hear from you for the next maybe 15 minutes. We promise not to keep you past 9 o'clock. I think we have some questions and some hands being raised, which is awesome. We can't wait to hear what you all have to say. But if there are some of you who are still processing all of the graphics and the trends that Spencer just talked about, 3 questions that I wanted to share that are top of mind for us that might spur some thinking on your part. I'd be curious to hear which findings resonated with you, or maybe if there are any that didn't match up with your experience and why that is. Also, based on your experience, what do you think might be behind some of the trends that we presented today? If it's not something that Spencer already covered as sort of a finding or a hypothesis of ours. I'm thinking, for example, about the greater volume decreases that we saw for breast cancer treatment as opposed to the other types of cancer included in our analysis, or the smaller decrease in substance use services that Spencer covered relative to other types of care. And then finally, knowing that we really need action to tackle this issue, where do we go from here? A lot of you are with health systems or hospitals or working as consumer advocates. What are your recommendations for focusing outreach efforts or targeting other support so that we can do our best to mitigate some of the harmful effects that we are currently still in the midst of with the pandemic, but how can we best address this? So with that, we'll go ahead and just kick it off for Q&A. And I think Joe's gonna ask our first question.
Yeah, one on first question is kind of a methodology question. It's about, was the incidence of disease in 2020 different than 2019? Was that factored into expected visits? So if I could add to that, we didn't really have a flu season last year. Did our analysis control for that?
Spencer, do you want to take that question?
Oh, sure. Yeah, sorry about that. Yeah, so that's a great question. We didn't really adjust for things like that. We used volumes from 2019 compared to volumes from 2020. So that was not factored into the analysis.
Right, and then next question also from Martha. Is it assumed that missed pediatric visits resulted in any missed immunizations?
Yeah, I saw that question. That's a great question. I'm sure in some cases that missed pediatric visits led to some missed immunizations. We don't have that level of detail in the data, so we're not able to kind of track that down. I know from speaking with some pediatricians that those immunizations and that immunization schedule was a big reason why pediatricians were trying to get those younger children in for their visits so they could keep them on that regular immunization schedule compared to some of those older children who weren't due for vaccines. So I know that was an emphasis, but we don't have the data to really track exactly how successful that was.
And I will just note, not to put him on the spot, but somebody I saw in our participant list is Dr. David Keller, who may have some other insights to share about that as well from Children's Hospital.
Yes, and I've just unmuted Dr. Keller. He had his hand raised anyways.
Yeah, well, I had my hand raised. So 2 thoughts on that. The first is your data you were looking through was through January 21, right?
Through December 2020.
To December 2020, right? So the question about not having a flu season last year doesn't really matter. Flu wouldn't have hit until January. And actually, at the time COVID hit, we were in the middle of one of the busiest respiratory seasons we see. If you looked at our volumes in February before COVID, we were actually seeing many more kids. Our ERs were crowded. We were admitting kids, and it all just shut down. So while yes, there was a change in the epidemiology, I think the numbers you saw really reflected the impact of COVID. And second, to the question of immunizations, according to CDPHE, which has the CIIS database, yes, our immunization rates are down. There were missed immunizations associated with those missed clinical visits. So I'll let you guys keep talking.
Thanks, Dr. Keller. That was really helpful. And that actually answered one question that I had been thinking about. I can't remember exactly which graphic it is, but you may remember that one of the early graphics that Spencer showed about care volume, the very first one was actually slightly above 100% of average right before the pandemic in March. And I was wondering, why that was. And so maybe your point, Dr. Keller, that we were actually in the midst of a pretty serious respiratory illness situation right before COVID might have explained the fact that volumes were even a tad bit higher than normal before March.
Question in the chat from Dr. Keller. I don't know if it might be partially rhetorical. Outreach is great. Someone needs to pay for it though. Who?
Yeah, no, that's a great question. I think that's kind of always the question when we get into moving from identifying the issue to finding the solution and kind of what the policy solution is. So I appreciate that flag by Dr. Keller. I think it's, I guess my personal bias is that it would be worth some investment in from policymakers.
Right. Another question, was the availability of appointments part of the analysis? Person's health system restricted access, number of appointments, hours, suggested delaying non-urgent care. Was that part of what we looked at?
Yeah, so that's a great question, because the appointment schedules was not really part of our analysis. We just had the data on how many visits were delivered in 2019 and how many occurred in 2020. But it's a great question, because we know that it was not just patients deciding, I don't feel safe going in to get this appointment. We know that it was also the case that some, particularly early on, some providers had to shift to this sort of triage of figuring out how to operate in a COVID world and who was most important to get in. And we know that that sort of difficulty in scheduling and sort of the supply side drove some of the decreases in volume as well. So it was not just patients just choosing not to go in. I want to make sure that we're clear about that. It was also we mentioned the public health orders that prevented for a bit some of those elective non-emergent procedures, and some providers who were exempt from those orders opted into them anyway. So it was both a supply and a demand side thing. We don't have the data to really unpack how much was column A and how much was column B.
All right. Were urgent care visits part of this? Or are they presumed to be replacement visits for the reduction that our data show?
Yeah, that might be our first question. That's really a Paul Preskin question to answer. I'm afraid if I'll get it wrong if I try, but that's a great question. And if we don't have Paul here to chime in, we can follow up on that.
Yeah, we knew there was going to be at least one, so we'll make a note of that and confirm. But
it looks
great
like
question.
I do see Paul. I'm not sure if he's available.
Yeah, Paul, if you're available, you can chime in to talk now. Otherwise, we can come back to you.
Can you repeat the question? I'm sorry, I'm here.
Yeah, the question is, were urgent care visits part of this analysis? Are they presumed to be a replacement for the visits for the 25% reduction in overall visits that we saw?
That's a good question. I don't believe urgent care visits were part of the analysis, just based on who provided the information. So that it's not part of the equation, unfortunately. But that's a good question. We should look in to see how those replaced or were also reduced during the pandemic.
Great, thanks, Paul. And I think we would, there's probably no chance that somehow urgent care filled the entire 25% gap, because I mean, people are not going to get, say, their cancer care and specialist appointments at urgent care. Another question, our final one in the queue right now. So add some more if you would like, everyone. Older populations are affected by transportation issues, caretaker availability to take appointments, as well as to an appointment that is due for a senior member that they relate to. Maybe more of a comment than a question, but it's or maybe a policy angle to look into, that it's not just especially for the older populations where we saw the drop off here. This isn't just a matter of a person's preference or availability of a provider, but transportation and the caregiver workforce also was greatly affected by the pandemic. Allie or Spencer, either one of you want to add anything onto that?
No, just that it's a great point, and it may again explain that trend that Spencer walked through, that except for some of the younger kiddos included in the analysis, we generally saw greater access challenges or greater numbers, at least, of missed visits as people aged. Spencer made the point that, you know, older Coloradans are more likely to have more healthcare visits, and so that's certainly part of it. But things like transportation challenges or caretaker availability also may have factored into the greater percentage of missed visits that we saw there. So thanks for adding that.
Great. One more question here. Are you able to break out the use of services in this study by telemedicine versus in-person? I agree, some services like behavioral health lend themselves better to telehealth, but curious if you're actually able to see that in the CHORDS data.
Yeah, absolutely. And that's a great question. So we didn't include that breakout in the paper of ambulatory versus telemedicine. We are able to see that in the data. We have a flag that tells us whether a particular encounter is either in person or via telemedicine. And I think within telemedicine, we can see if it was a phone visit or a video visit as well. Paul may want to jump in with details of sort of what happened, but overall, the behavioral health is really where we're seeing the largest uptake of telemedicine visits. And really early on in the pandemic, we saw a huge increase in behavioral health visits for telemedicine. We put out a paper, I guess it was last year, with the Office of eHealth Innovation that used the CHORDS Data Network actually to look at this exact question of telemedicine versus ambulatory. It wasn't really the focus of this one, but we were seeing that particularly for behavioral health, there was a bit of staying power, as Ali mentioned, for telemedicine. We were seeing that continue through the end of the year, where it was not something that just happened in the beginning of the pandemic, particularly for those services. It seems like the paradigm may have changed a bit for how those services are delivered. Paul, I did reference you. I see you came off mute. If you want to chime in, feel free.
Yeah, I wanted to say that in general, we saw a huge uptick in telemedicine right as the pandemic began. Without it, I think we would have seen an even larger decrease in the amount of care that was foregone. After the late spring, telemedicine started to come back down as people started to come back in to see providers in person. But it never went away. Even at the end of 2020, there was still a substantial amount of telemedicine still being provided. So, and a pretty consistent amount of it. So telemedicine definitely is part of care delivery. Without it, we would have seen even larger drops. So.
Right, a couple of positive Yelp reviews here. Martha says this is a terribly important study. Thanks for doing it. It should have national attention. All right, thank you. Tell a friend. And will this analysis be extended another year? It's really interesting. Allie, that maybe is a question for you.
Yeah, that's a great question. We haven't talked about that yet, but I agree that it is super important information. And given that we were only able to really go through the end of 2020, which, as we all know, unfortunately was not the end of the pandemic, I would love to see us be able to look at 2021 data and see how these trends either worsened or improved, or probably some mix of both, as the case rate and hospitalization rate changed this year. So have not committed to doing a next year yet, since we just published this one, but this is great to hear that this is resonating with all of you and that you think it's useful. So if others feel that having another year would be of value, it's certainly something we should consider. So thanks for asking that.
Yeah, and I would actually, I'd love to further dive into Dr. Keller's question of, well, the overall question of, these are the data, what should we do about it? And then specifically Dr. Keller's question of, how do we pay for it?
Right. Well, that's a great note to end up on. I'd like to thank everybody for attending this morning. Allie, Spencer, thank you, and Paul, thank you for this this great work that you've done. It's it really is important data to have for all of us who care about our friends and neighbors here in Colorado. With that, we will bring the webinar to an end. Remember, we will have it posted late today, we hope, on our website. So just scroll to the bottom of the homepage, click the silly little Eggheads icon, and you'll be able to see it right there. Thanks very much, everyone, and enjoy your Friday.
Thanks for being here.